H1N1 pandemic. My name is Nora and this is Public Health. For the 6-step analysis, step 1, H1N1 virus contained a mixture of swine, avian, and human influenza. It was first detected in California in April 2009. The virus was transmitted from person to person, targeting youth, becoming a pandemic. Step 2, the World Health Organization declared that H1N1 a phase 6 pandemic. By 2010, there were millions of deaths and cases worldwide. H1N1 virus targets children, young adults, and pregnant women. Despite vaccine production, supply shortage was an issue. After the mid-2010 cases began to decline. Step 3, the issue was due to limited vaccine supplies, rapid testing, lack of immunity in youth, and underlying conditions that increase the risk. Step 4, the CDC activated Emergency Operations Center, distributed PCR diagnostic kits, limited travels, and developed vaccines. Effective antivirals were stockpiled, and communication was ongoing. Step 5, testing should be expanded and should detect new strains of virus quickly. Vaccines and antiviral supply should meet the needs and distributed evenly. Communication and surveillance should be maintained. Step 6, vaccines should have been ongoing with awareness campaigns to get vaccinated. Essential equipment should be supplied. The responsible groups can include CDC, FDA, and so on. As soon as the first cases begin, there should be quick responses by the CDC activating their Emergency Operations Center before others get infected. On April 15, 2009, a new strain of H1N1 influenza, known as the swine flu, was first identified in a 10-year-old patient in California, although it did start in Mexico. What made it especially unusual was that it also contained elements from human and avian influenza strain, making a new virus that infected humans rather than pigs, because pigs were the main host for these viruses. Initially, the virus was resistant to antivirals like Tamiflu. Transmission was through airborne droplets. Although a vaccine was eventually developed, access to it wasn't equal across all populations. The virus primarily affected young people, and children were at most risk. Due to the rapid spread and impact, it was declared a pandemic. By 2010, the H1N1 pandemic had significantly impacted the U.S., resulting in around 50 million illnesses, 265,000 hospitalizations, and 12,000 deaths. Social and cultural factors heavily influenced public response as fear and misinformation spread quickly, fueled by memories of the SARS in 2003 and past flu scares. This increased vaccine hesitancy. Globally, coordination efforts were complicated by the difference in healthcare systems. Economically, the Great Recession had already stretched government budget thin. Widespread illness led to high workplace absentee, and government had to make tough choices, balancing the cost of vaccine, antivirals, and protective equipment with limited resources. Certain population groups were hit harder than the others, such as younger children, pregnant women, and those with chronic conditions like diabetes. Interestingly, older adults over the age of 65 had partial immunity, which influenced who was prioritized for care. The graphic shows an increase in hospitalization in 2009, and after you can see a plateau afterward. This change is largely due to the measures that were put in place, such as vaccination or school closures. The H1N1 virus was a new influenza A strain combining swine, avian, and human genes, and this caused little natural immunity, especially in children. While some older adults had partial immunity from past exposures, the virus spread quickly, and the delay in response and slow vaccine rollout worsened the situation. Looking at the core issues and opportunities, it became clear that protecting high-risk groups like children is important. Equitable vaccine distribution across different communities and regions is essential. In addition, ensuring frontline workers had access to personal protective equipment, surveillance, and communicating transparency with the public is essential. Speeding vaccine production and gaining public trust are key opportunities for improving future response. The socio-ecological model provides a framework for understanding how the 2009 pandemic response required actions at all levels. Here I created a diagram describing the model. At the individual levels, people are encouraged to get vaccinated, maintain hygiene, and stay home when sick. At the interpersonal level, families must be given guidance on caring for the sick and encouraged to keep children out of school. Parents must vaccinate their children, especially as they are more at risk. At the organization level, schools and hospitals design effective control strategies like setting up vaccination clinics. I also mentioned how schools were also online. At the community level, local health department organized free vaccination drives, partner with community leaders to provide vaccination trust. And at the policy level, national and global actions such as CDC and WHO pandemic declarations, funding, ensured resources were available. And two solutions to control the spread include school closures and household antiviral prophylaxis. Longer school closure, especially when paired with antiviral use, helped reduce the peak of the epidemic, slow the spread, and also gave time for vaccine rollout. On the contrary, treating infected individuals and their household with antivirals significantly lowered infection rates from 32.5% down to 13%. Antivirals required a large stockpile to be implemented successfully. Maintaining a strategic national stockpile and ensuring rapid distribution through pharmacies and hospitals are vital for pandemic preparation, enabling timely access to reducing severe illness and death. Another analysis found that improved global surveillance and notification during the pandemic enabled earlier detection, faster MCM distribution, and timely clinical guidance, helping contain the spread and reduce harm. Late pandemic surveys showed that trust in government and clear communication boosted vaccine intent. Surveillance is important to maintain the outbreak. Enhanced surveillance began in April 2009 with expanded testing, contact tracing, and rapid PCR test distributions. It was led by CDC, WHO, and local health departments. Testing scaled up over the next 3 months. A full-scale emergency response was activated in April 2009 and continued through 2010. The response involved coordination between the CDC, Department of Health and Human Services, and various states and local agencies to manage the evolving situation over a year period. Starting April 26, 2009, the Strategic National Stockpile released antivirals and PPE, supported by the EUA and resistant monitoring. Managed by the CDC, FDA, and state agencies, the effort continued through 2010. Vaccine development and approval began rapidly in 2009, involving the CDC, NIH, FDA, manufacturers, and local health departments. By September, the vaccines was approved, and nationwide campaigns ran from October 9 to early 2010. From 2009 to 2010, the CDC, local health department, and media ensured effective public communication, providing timely, accurate information to address public concerns and encourage prevention. And in my opinion, the H1N1 response shows how early preparedness and communication with vaccine distribution are most critical factors in controlling future pandemics, especially the 2009 pandemic. Thank you.